All of these things can basically fall into this interstitial syndrome pathology. And if we were going to talk about this, this would be the whole talk today. It's a huge bucket. So I'm not going to focus on that as much, but what I'm going to focus on is for evaluation of pneumothorax, for evaluations of consolidations, and for pleural effusions. And I created this algorithm. It's not been validated anywhere. This is just something that I do when I am seeing my patients in helping me think of what are the next steps and what things should I be thinking of when a patient is hypoxic or dyspneic. In my patient population, because I'm a cardiothoracic anesthesiologist and an intensivist, the first question I always have for myself is the heart okay? Because they could be hypoxic or dyspneic because of heart failure. So the first thing I kind of really want to know is, do I have a clear understanding of what the heart is doing? And if the heart function is relatively normal, then the next question I ask myself is there lung sliding? And that question, whether it is yes or no, helps me move down the algorithm. And so we're going to go over this and we're going to apply this algorithm to a number of different cases. Before we do that, I just wanted to show you normal and abnormal. So when we talk about lung sliding with lung ultrasound, this is a linear probe. You can tell because it's a square-shaped image that the ultrasound is giving you. You can see the rib with the rib shadow here, and probably the second one is off the screen here. And the pleural line is this bright line that usually lives half of a centimeter below the ribs. So you can identify the ribs. The ultrasound probe is being held with the orientation marker towards the patient's head. This would be the patient's head. These are their toes. And here's a rib, and here's that bright pleural line. And you can basically see that in that pleural line that is moving back and forth, it looks like ants are marching. It looks like they're shimmering. You can see these shimmering reverberation artifacts called B-lines that start from the base of the pleural line like a flash of light, and they go all the way down to the bottom of the screen. You can see the pleural line moving. Now, when you evaluate this with M mode, what you would do is you can put M mode, which is what's called motion mode, on that pleural line, and motion mode picks up motion when there's movement in ultrasound. And so what we can see when we put M mode across that pleural line is we see the bright pleural line here, and we see a bunch of stasis, which is the chest wall, chest that isn't moving, but where the visceral and parietal pleura are rubbing against each other, you get this motion-like artifact that creates the smudging appearance, makes it look like a sandy beach. So we call this the sandy beach sign. You're standing on the sand and you're looking at the water here. This is a normal finding. If you see this, and this supports your understanding that there is lung sliding. So let's compare this lung sliding image here, where you can see the shimmering back to and fro motion of the pleura, to this one here. Here are the ribs. Here is what we would think would be that bright pleural line, but instead we see no to and fro motion. We see no kind of glistening or glimmering. There are no B lines coming down from that pleural line, and all you can see is basically the chest wall thickening as the patient is trying to use their intercostal muscles to take a breath. So this would be no lung sliding, no B lines. Here is lung sliding with B lines. Okay, and I'm just going to take that away so you can focus on it, and then basically just make it a little bit bigger so you can see that there really is no lung sliding here. Now, if you were to do the same thing you did before, which is put M mode over the pleural line and evaluate to see if there was motion that was visible, you would get, instead of that sandy beach, you would get this thing that we call the barcode sign, which basically means the chest wall area that was static and not moving, that lack of motion is propagated across the entire screen. And you no longer get that sandy beach sign, you just see stasis all the way through. So this is another way to kind of validate that, yes, indeed, I don't see any lung sliding. Okay, and just to kind of zoom that up for you to see the barcode sign, like you're at a store and they scan the barcode scanner. Now, and this is really important. And if there is one takeaway I have for you for today, is just to say that using lung ultrasound to evaluate for a pneumothorax, it's a very specific, it's not very specific. So meaning that it's really easy to rule out a pneumothorax using lung ultrasound, but it's much more challenging to rule it in. What I mean to say is if you don't see lung sliding, you need to ask yourself other questions, because you can't just say, oh, no lung sliding, it's got to be a pneumothorax. If you don't see lung sliding, you have to basically go down the pneumothorax algorithm to then ask yourself, are there B lines, yes or no? Because a patient will not have B lines if there is no visceral and parietal pleura to and fro motion. You will not have B lines. So the next question is, are there B lines? Yes or no? If there are B lines, it can't be a pneumothorax. After that, if you don't see B lines, you ask yourself, is there a lung point? Yes or no? Which we're going to cover what that means. And then after that is there a lung pulse? Yes or no? So what does a lung point mean? A lung point is basically the point at where the pneumothorax, basically the visceral and parietal pleura, kind of separate from each other. It's the margin of the pneumothorax. And it can be very specific if you see it in the anterior lung fields. Okay, and I'm going to show you an example of what that looks like. Basically, when the patient breathes, the pleural line will start to slide. And then as they exhale, it'll fall off because you're scanning here and you've caught the zone or the margin of the pneumothorax. Now, be very careful in patients who have blebs, because we thought before that if you saw this in the anterior lung fields, then there was no way a patient could have a pneumothorax. But in 2015, we started getting more and more reports that as we were doing more lung ultrasound, that if the patients have blebs, sometimes you'll see what appears to be a lung point in the anterior fields, and it's not necessarily a pneumothorax. But in general, if you are seeing this in the anterior lung fields in the absence of A lines, which we'll talk about, that is pretty pathognomonic for a pneumothorax. So here's an example of a lung point. You see the pleural line slides away, and then there's a to and fro motion here, and then it suddenly disappears and you no longer see lung sliding. What about here? You see the pleural line here shimmering, and then it slides away, shimmering, and then all of a sudden it goes away, and then you don't have lung sliding there. Or here, this is another really great example, rib, and you see the pleural line sliding back and forth. So this is a lung point. When seen in the anterior lung fields, it's very, very pathognomonic for a pneumothorax. But what if you don't see a lung point either? Then the next thing you have to ask yourself is there a lung pulse? And what a lung pulse means is that the visceral and the parietal pleura are actually in contact with each other, but the lung is not very well aerated. And for that reason, as the heart beats, it causes this pulsing to and fro motion of the visceral and parietal pleura to give you almost like a pulse appearance of the pleura. But that doesn't mean that there's no lung sliding because of a pneumothorax. It just means that there's a lack of lung sliding because the lung is poorly aerated. You can see this in patients who have consolidative processes, or maybe aren't a lot of PEEP with the ventilator, and you're scanning the anterior portions, the apices of the lungs that remain inflated. So as we work down the algorithm, you can see that the lack of lung sliding can be seen in a number of different pathologies, in ARDS, in bullous lung disease, in pneumonia, fibrosis, the list goes on and on. So that's why it becomes really important to work through an algorithm to make sure you know that what you're looking at really is in fact a pneumothorax. We can also use lung ultrasound for evaluations of consolidation. If you see consolidation in lung ultrasound imaging, it almost looks like the lung has turned into tissue. We call it hepatization of the lung. And typically what will happen is when you're evaluating the pleural line, you may see a lung pulse because of a lack of aeration in that area. So the lung can't adequately inflate and deflate over the respiratory cycle. Sometimes you can see air bronchograms, which I'm going to show you, static versus dynamic air bronchograms. And you oftentimes see a non-homogeneous distribution of V lines. This can be seen in patients who have atelectasis, a pulmonary infarction, lung contusions, pneumonia, lung cancer, all of these apply. So here is a patient I had in the ICU who was prone. So that's why this looks a little bit challenged or different. This patient had a pneumonia and was in respiratory failure. And she was prone, and I did this ultrasound, you can see, with that curvilinear broad-based probe. And you can see here, this consolidated lung looks almost like a solid organ. It's hepatized. It's surrounded by a pleural effusion here, which is the black material that you see surrounding the lung. And within the lung, you see basically these static air bronchograms, which look like these bright specks. We call this the starry sky. And if you focus really closely coming up here, you will see a couple of bubbles rising up and down right here in one of those air bronchograms right there, which is a picture of a dynamic air bronchogram. Think of it like bubbles or mucus or secretions bubbling up in and out of the alveolar, the bronchial tree. So here's another better example of what a dynamic air bronchogram would look like here. So I'm going to play this for you. This is now, we're looking on the right side. Look here at these bubbles kind of going up and down as the patient breathes. So this patient had a right lower lobe consolidation. Here's the liver, here's the diaphragm, and you saw these dynamic air bronchograms with almost like mucus bubbling up and down in the airways. This is pathognomonic for a pneumonia. So this consolidated process was because of a pneumonia. So I want to apply this algorithm to our first case. We have a case of a 35-year-old male who was recovering from COVID pneumonia. He was on trach collar in the ICU, and he became acutely dyspneic. Was doing well, all of a sudden dyspneic, hypoxic, and started to get hypotensive. Fluids were initiated. This was at 2 o'clock in the morning. Fluids were initiated, vasopressors were started, and I grabbed an ultrasound machine because I was on nights, and we called for an x-ray just kind of all at the same time. And so I'm thinking to myself, what could this be? This, you always have to have a question in mind when you're doing ultrasound. And I was worried about a number of different things, but to become acutely hypoxic, I was thinking of an acute process. Did he have an acute pneumothorax? Did he have suddenly bleeding in his chest for some reason? Did something happen? Did he have an MI and suddenly have a heart failure? Well, luckily his echo was normal, and we had done one earlier in the day. And before this, there was no signs. There had been no EKG changes. So my suspicion here was really low. So then that's when I started to look for lung sliding. So normal, you go ask yourself, is there lung sliding? So this is the way his lung looked in the right 2 region on the right side, the second anterior region. And you can see the ribs here. I use that curvilinear probe, and there's lung sliding here back and forth. You can see B lines. Now compare that to the left 2 region. So the ribs are here and here. This is where you would expect the pleural line to be, but I really didn't see any lung sliding. Okay, so then I asked myself, okay, lung sliding, no, then I need to initiate the pneumothorax algorithm. So the next question that I'm going to ask myself in part of this algorithm is, if there's not any lung sliding, are there B-lines? Do you see those comet tail reverberation-like artifacts that start from the pleural base and go all the way to the bottom? I didn't see those. I didn't see the flashes of light that I would expect to see in a patient with normal lung sliding. So then I had to start thinking, there's no B lines, there's no lung sliding, there's no B lines. So let's look for a lung point. And I scanned up and down the whole chest, and I didn't see a lung point. So then the next question I had to ask myself was, is there even a lung pulse? Do you see that to and fro motion like the heart is beating and causing the pleural line to and fro in a rhythmic fashion? I don't really see that here either. So now my suspicion for a pneumothorax was very high. As I called for the needle. I need a needle to decompress this chest because the patient's getting hypotensive. He's very dyspneic. And as I'm getting ready to do this, I got the needle. I'm trying to prep the chest. They come with the chest x-ray. And I said, no one's going to believe me. No one's going to believe me. So let's get a chest x-ray. It's here anyway. Let's get it. And this is what his chest x-ray looked like. So you can see the diseased lung from his COVID pneumonia, and he had complete collapse of his left lung and some tracheal shift over to the right. He had a tension pneumothorax.
5-minute reminder.
And then, thank you. And then we decompressed the chest. So remember, this is how it looked beforehand. No lung sliding. I needle decompress the chest. And this is in the same exact spot what happened afterwards. You can see the ribs and the pleural sliding back and forth. So just really quickly, the second case I have is of a 32-year-old female who's pregnant. She had premature rupture of membranes and contractions. We were called by the OB team because they were concerned she was hypoxic and had early fetal decelerations. And their concerns were based on these vitals. She was tachycardic. She was maybe a little hypotensive. She was hypoxic on 5 liters of oxygen. They had started antibiotics, they were giving her crystalloids, and some labs were pending. And so I went down and I said, well, I don't know anything about this patient, so let's do a quick TTE and look at what we saw. She had biventricular heart failure, right and left heart dysfunction. This is a peristernal long access view, RV, LV, aortic valve, mitral valve, left atrium. Then when we got the 4-chamber image, this is the LV, the RV, the right atrium, the left ventricle, you can see once again that she's got biventricular heart failure. And the reason I put this up there is to say that in patients who are septic, their extravascular lung curve, which you see here, gets shifted up. So even though they may be fluid responsive, you get a large increase in cardiac output based on the Frank-Starling curve. For that same patient, once they're septic, they get more extravascular water when given fluid. And when you reach the plateaued area of the Frank-Starling curve, you basically get this large increase, even more increase in extravascular lung water with administration of fluids. So, the question we have to ask ourselves after we see a normal an abnormal heart are there diffuse B lines? Is there lung sliding and diffuse B lines? And so we see here 2 ribs, the pleural line, and all of a sudden you see these flashes of light like beams coming down from the pleural line, so bright, diffuse everywhere in the patient's chest, which is really pathognomonic for pulmonary edema. And just to say that, we have capabilities with lung ultrasound, that I looked further into the chest to see if there was a pleural effusion as well. And my computer is now trying to think about what to do. So let's see if we can wait for this program to respond. But I looked and, the patient also had a pleural effusion. So this is just an example of how you can use lung ultrasound. She had basically decompensated heart failure, and this patient needed to be diuresed, put on BiPAP, and all of those features. So I'm having some computer issues here for some reason, but
one more minute left before the end of the session.
Okay, so we have 2 minutes left anyway. I just wanted to quickly look and see if there were any questions in the chat or any questions you all had for me in the application of lung ultrasound for the care of your patients. I'm trying to see the chat. Let's see.
And maybe stop
questions in the
share so we can see people.
Yes, let's stop the screen share. So feel free to open your videos so we can see all of your faces. I'm so excited to have you join here today. Any questions for me about the use of lung ultrasound, or any questions about those cases? I'd be happy to answer any questions you have. I just wanted to...
There is no chat. Yeah, so you can unmute yourself and ask your questions, everyone.
And I just wanted to say thank you all so much. I know you're all coming from very different time zones. Thank you for joining in on this session here today. What we're hoping with this collaborative is, you've seen kind of this case series and the way that we did it. What we're hoping for is an opportunity for us all to grow and learn as a community, for there to be some perspective we can offer for the application of lung ultrasound in the cases that we do, and also to learn from you to understand what cases you see and how you're applying lung ultrasound. I'm hoping that in May, maybe one of the institutions here, our global partners, would be willing to do a case presentation. We'll present again in March and April, and then hopefully in May. If any of you are interested, please, we would love for that to help work on this collaborative.
We have a couple questions, Dr. Nikravan.
Yes.
The role of lung ultrasound for diaphragm excursion, sensitivity and importance in the ICU, and then what is the sensitivity of ultrasound in diagnosing pulmonary edema?
I'll answer the second question first because it's the easier of the two to answer. It's very sensitive. And actually, if my computer had not glitched there at the end, you would have been able to see that I provided a slide that kind of showed the sensitivity of all the different pathologies. So for ruling out a pneumothorax, it is top. It is highest sensitivity because you can see lung sliding. If you see lung sliding, then you're done. It's not a pneumothorax. Okay, that's super easy to rule it out. Ruling it in is much harder. And for pulmonary edema, there have been a number of studies done. One of the studies that I showed you, which was the one that basically showed us how to do the lung ultrasound, was the algorithm for scanning where you divide the chest into 4 quadrants. They basically looked at B lines in patients who had end-stage renal disease and scanned them before dialysis and counted the amount of B lines in a lung field, which is between 2 rib spaces. And then they scanned them again immediately after dialysis. And what they saw was that the number of B lines was reduced. And what we know is that if you see greater than 2 B lines within a lung field, so 3 or more B lines within a lung field, then that is in a homogeneous sort of a spread. So meaning it's not just in one little area, it's equally crosses the screen, then that has been very sensitive for pulmonary edema. In regards to your question about the diaphragmatic evaluation of the diaphragm in the ICU, to be honest, that has been a little bit more challenging because some patients' diaphragms are very hard to visualize, and especially in critically ill patients, they can be atrophied and hard to visualize. And a lot of that diaphragmatic thickening and diaphragmatic excursion is based on effort, just kind of like a PFT. So maybe the patient isn't providing the effort to cause the diaphragmatic thickening or excursion that we would want to see, or maybe it's just that they can't. And it's been harder to kind of suss that out. So I think there's a little bit more work to do in that space. I don't think we've quite given up on it yet, but it's not something I routinely use because I don't feel like I can reliably trust it. In the pediatric patient population, it's being used more because those patients, of course, kids are very robust and they have a lot less tissue to scan through. So the diaphragm is much more easily visualized on them. So in that space, it's been used a little bit more. But yeah, it's still, I don't think, where it needs to be for adult evaluations.
One more question, if there's time. How do you differentiate B lines from other reverberations?
Yeah, so that is kind of the big question. So the B lines are reverberation artifacts, like beams of light almost. They come from the pleural line and they go all the way down to the bottom of the screen. So I'm going to see if I can very quickly, if I can share my screen again. I'm going to go back to this presentation. It's still not working. Okay, so I'll unshare it. They start from the pleural line, or can you see it here?
Yes.
Okay, so you see how here you have this flash of light. It starts all the way from the pleural line like a bright light, and it goes all the way down to the bottom of the screen. Now, if I had a line that didn't go all the way to the bottom of the screen, but was just like a little reverberation line that went midway down the screen, then that would be a Z line. And that's just a normal artifact. That's not pathologic. How do you differentiate a B line that you see in pulmonary edema from a B line that you see, for example, in ARDS or pneumonia, or another consolidative process? So, it's a combination of a couple of things. One is you want to look at the pleural line itself, because the pleural line should be crisp and clean. It should be clear. It shouldn't look chewed up and basically almost like eaten up. It should be nice and clean. The other thing that you want to make sure is that the B lines are in pulmonary edema. They cover the screen. There's not certain, like in one focal area each time on the screen, no B lines show up there. We call that kind of patchy distribution of B lines. And that typically happens when patients have some sort of consolidated process like you would have with ARDS or pneumonia, for example. So you're looking for kind of this homogeneous distribution of B lines across the screen. Does that answer your question? What about accreditation? This is like the hot potato. There's no way I could answer that question in the 2 minutes that we have left. There's currently no nationally recognized accreditation process for point of care ultrasound in anesthesiology. The emergency medicine group has created kind of a process within their own specialty. And within our specialty, the American Society of Anesthesiology has put together a certification process that with a course that you can take that has a series of exams you have to do and submit, and then they'll give you certification through the American Society of Anesthesiology. But that is not a nationally recognized accreditation process like, one thing like the National Board of Echocardiography, but it's nationally recognized within our specialty. So we kind of did a similar thing as to what the emergency medicine department did in that regard. So we can always chat a little bit more about that over the course of this collaborative. My suggestion is that you engage in experiences like this one, take the ultrasound, start doing the scans so that you can get familiar with them, building up a system for quality improvement and and image capture is really important for being able to make sure that your providers are able to confidently build up their skill and ability to confidently do point of care ultrasound. But there's no clear nationally recognized accreditation process that's cross specialties as of yet.
Also, I want to say our next session is March 22nd with Dr. Melanie Liu. She'll be talking to us about vascular access. So just make sure everyone, it's in your calendars.
Just wanted to thank everybody so much for your time here today. We're about 9 minutes over. I'm so excited that you were able to join this morning. If you have any questions or concerns, or also please, we're looking for one of our global partners to contribute to the case series in May. So if you would be willing to email myself or Bookie, that would be really great. And I would just challenge you to get out there and start scanning people. Get started. You can do this today. Lung ultrasound is super easy. Thank you so much for your time, and I look forward to seeing you in March.